Good morning, ladies and gentlemen. As the Chairman says, I'm a Director of HCAIS, which provides guidance for the NHS, as you know. And since the CMO report on antimicrobial resistance was published earlier this year, we've been in discussion with clinical advisors and officials at the Department of Health, and more recently with Public Health England, on how NICE can contribute to supporting the action that Sally Davis described. And there is a specific recommendation in her report regarding the development of guidance by NICE to reduce morbidity and mortality from healthcare-acquired infections. There are these two key programs that I lead at NICE, the Clinical Guidelines Program and Medicine and Prescribing, which includes a program of guidance called Good Practice Guidance, and both of these will feature in our response to the CMO report. Now, NICE has already produced an extensive range of clinical guidance on managing specific infections, such as meningitis, on managing possible infections, such as febrile illness in childhood, and on prevention, mainly through our public health program, and incorporating action to prevent healthcare-acquired infections. We sometimes recommend specific antimicrobials, but often we leave the choice of antibiotic to the professionals locally. And we have vigorously resisted the invitation from the Department of Health to recommend standard antimicrobial regimes, as we regard in most instances these to be better determined locally. My presentation today is going to look at the position leading up to the program of guidance, which will be forthcoming in the next 2 or 3 years. And an element of this is the role of our own guidance in contributing to the problem. Healthcare-acquired infection and antimicrobial resistance are separate but related issues, and I will touch on both. Drug resistance creates problems, particularly in hospitals, and contributes to the avoidable deaths that Sir Brian's been talking about. And to address this, I think we have to travel upstream to the source of the problem. So the problem is essentially that if you use antibiotics, you develop resistance. Equally, if you stop using them, the resistance declines. Most antibiotic use is in primary care. I think it's about 85% of antibiotic use is in primary care. And so much of the resistance problem began there, but it accelerates in hospital because hospitals have a habit of using multiple antibiotics. Public expectations for the management of infective illness have always been misplaced. I think they've improved, to be honest, but there is still too often an assumption that a high temperature should be treated with an antimicrobial. GPs have got much, much better at resisting this, but there is still a failure of public understanding about the appropriate role of antimicrobials. Despite significant advances, I think, in antimicrobial practice, overuse of antibiotics is rife, and a number of our own guidance documents may be contributing to this, and I'll say a bit about this later. Bacteria are everywhere, of course. There's some now, but bad bacteria tend to like to live in hospitals where we encourage their growth by spraying antibiotics in the atmosphere. So where are we now? The CMO says we're in a crisis. Some of us would think, well, we've got a big problem. It becomes a crisis if we don't do anything about it. And I guess that's probably where we are. As I've said, the use of antimicrobials and resistance to them are inversely related. And I guess there's an issue here in our neutropenic sepsis guidance where in a highly selected group of patients, we're encouraging the use of prophylactic fluoroquinolones. Now, fluoroquinolones went out of favor probably the best part of a decade ago because of the development of extensive resistance to them. Since that time, the prevalence of resistant strains has dropped quite sharply, not surprisingly. Now we're going to start using them again significantly, though, as I say, in a very small segment of the population. Will be interesting to see the speed with which resistance accelerates again. They've also gone out of favour because DH guidance says they're a cause of C. diff. When we looked at the evidence for this, it was staggeringly weak, but then that's not too surprising in DH guidance, is it? As I've said, the problem of resistance probably started in primary care, but hospital practice, certainly until a few years ago, accelerated and exacerbated it. We know that resistance can spread between bacteria, so you can't really segment this problem. And the race has been being lost for the last couple of decades. Industry's failure to respond to the problem, perhaps because of the high entry costs and low returns from antibiotics, is another part of the problem. So, going back to the problem of people, what should we tell the public? And most of this advice is already shared with the professions. It's just not understood by the general public. So for most febrile illnesses, we should say self-management is the norm. We should say don't expect a prescription for antibiotics in the absence of a proven bacterial infection. Always complete the course if antimicrobials are prescribed and take exactly as prescribed in terms of the timing of dosage. But as we minimize the use of antibiotics, hopefully, we should ensure that patients and their carers are alert to the signs of serious infection, which can, of course, develop very quickly and unexpectedly. And prescribers, similarly, should only treat bacterial infection, be guided by sensitivity analysis, use antibiotics for the shortest effective time. Whether they're using antimicrobials or not, patients with infective illnesses should be reviewed. This can be done by the phone. You don't have to call them in or see them face to face. But you shouldn't just send someone away and say, I'm sure it'll get better. You should review them. And if patients don't respond or seek advice, if patients don't respond either to treatment or to no treatment, then advice should be sought. So, NICE's contribution to the problem. The issue for me is that we promote the use of routine antibiotics to prevent infection, particularly in surgical procedures. Now, within the rigid environment within which NICE develops its guidance, this is an entirely legitimate thing to do. Trials show that the use of prophylactic antibiotics in many surgical settings is cost-effective, even if the number needed to treat is of the order of 30 to 40, which it often is. But what we do not take into account is the effect of this extensive use of antibiotics on the wider antimicrobial resistance issue. So around 60 to 70% of antibiotic use in hospital is as a result of or consistent with guidance on preventing infection in surgical practice promoted by NICE. And the impact of this is a matter of concern to me, and I'd be very interested in your views on this. The use of antibiotics routinely in the cesspit that is our hospitals encourages the development of resistance, even if it hadn't already developed. So let's now look briefly at the sort of program of guidance that's on its way. As I say, we've discussed this with the department and with Public Health England. Public health topics can be referred to NICE directly by the Department of Health. guidance topics on the delivery of healthcare and the practice of professionals come to us via NHS England, and we have not finalised our discussions with NHS England yet. So some of what I'm going to say is subject to agreement with NHS England, which and we'll be discussing this with them next month. But the idea of producing some sort of educational guidance for the public on the appropriate use of antibiotics is welcomed. This would come through our public health programme, which gives advice not to the NHS but to the wider community. So we can do that. We've been asked to look at guidance on antimicrobial stewardship. Now, our clinical guidelines programme, as you probably know, takes a long time and costs a lot of money. It takes typically 2.5 years from commissioning a guideline to its publication, and I won't tell you how much it costs, but it would scare you. So we would look to find a method of getting guidance out rather quicker than this, and in a way that's rather more engaged with the community than our clinical guidelines sometimes are. And we have this vehicle called Good Practice Guidance, which typically takes about 9 to 10 months, is very engaged with the field. It has a larger guideline group, it has a range of interactions and calls for evidence and expert witnesses and so on, which are outside our guideline methodology, and produces guidance to people on how they should do certain things. So I think this is the right vehicle for producing guidance on antimicrobial stewardship. We are not yet decided whether to do this separately for hospital and community settings, so I'd be interested in your views on that too. Now, within the CMO report, as I said earlier, was this suggestion that NICE should produce guidance on reducing the morbidity and mortality from healthcare-acquired infections. And this does lend itself to a standard clinical guideline approach. There's a decent literature on this, and I think that is probably the right way to do it. It will take time, of course, but this is a slow-moving beast anyway. So again, I'd be interested on your views on that in the discussion. As you know, when we do develop guidance, we spend some time scoping it carefully, and I suspect some of you will be involved in that process in due course. The main purpose these days of developing guidance at NICE is to populate a quality standard, and what is going to initiate this program would be the referral of additions to the Quality Standards Library on antimicrobial stewardship and healthcare-acquired infection, and that will be the first step in the program, hopefully before the end of the year. And then our guidance will help to populate those quality standards. We can also use guidance developed by other organisations whose processes have been accredited by NICE, and there are now about 60 organisations worldwide who have NICE accredited guidance, and there will hopefully be some. The Royal College of Paediatrics and Child Health and the Royal College of Obstetricians and Gynecologists and the RCR, for example, are all accredited organisations for their guidance. So hopefully we'll be able to call on guidance from other sources as well as our own to populate the quality standards. Time-wise, I think we're looking at 2017 for the standard on healthcare-acquired infections, maybe 2015 for antimicrobial stewardship. So the conundrum really is this: what should we do about our existing guidance on promoting antimicrobial use? How much does it contribute to the overall problem? Is it enough, in fact, to to limit our guidance and reduce the routine use of antibiotics, even though we know that would result in an increase in, for example, post-operative infection. And I'm not sure that anyone's ever studied this topic, and perhaps now is the time to start. I'm certainly not going to suspend our guidance in this area for now, but I think it will be useful to have a debate, perhaps not here, but somewhere, about the contribution that routine prophylactic antibiotic use in hospital makes to the overall problem of antimicrobial resistance. I have long learned that you shouldn't write everything down because people can call on it. So my final comments do not take the form of a slide. I think the issue of infection control and targeted measures to address them runs the risk of substitution. We've already seen some elements of this in meningitis, where a vaccine is produced against one strain and another strain stands up to take over. It is certainly possible that this has already happened in the field of healthcare-acquired infection. And the focus on MRSA and C. diff, largely successful, has masked the emergence of other hospital-acquired infections. So we are intending, when we do develop our healthcare-acquired infection guidance, to look at the topic in the round rather than specifically target those conditions that are already the subject of extensive Department of Health guidance, though of course we won't ignore them. The improvements made, particularly in MRSA and C. diff, mean that now most avoidable hospital deaths from infection are from other causes. And these are, as I say, masked by the focus on MRSA and C. diff. There's also been a recent Ombudsman's report on sepsis, with the usual Ombudsman tale of woe about studied neglect, ignorance by staff, and the failure to diagnose and competently treat infection, resulting in death from sepsis. We've been peripherally involved in some of the discussions around this, and there was a roundtable meeting at the House in July, I think, just before the report was published. We have now had the sepsis topic referred from NHS England to us for both a quality standard and now for a clinical guideline as well, and so we'll be putting that guideline into the programme in the near future. So, if it wasn't already, infection has become important again for the NHS, and I've no doubt most of you will spend the rest of your careers dealing with its importance. Thank you very much.